aiming at that.
Okay. Yes.
Okay. So anyway, I had a look at what was going on, and I knew a little bit about this whole subject, and I thought, boy, it's going to be about 10 minutes by the time he gets to school. And they're going to be writing the note home and saying, you need to get your son checked out because he can't sit still, etc. So that's kind of what got me started. But I've been in mental health field a long time. I actually started out as a teacher, and before that, my undergrad was in chemistry. So I have kind of an unusual combination of experience that makes me really interested in scientific studies and how they are interpreted and applied to this field. So we'll talk a lot about that in a minute. But let's start by talking about Patrick. So,
Steve, is the mic on this time?
it is on. It was on the last time too, actually. It was how I translated it.
Okay.
So I call this We Survived ADHD Without Drugs for a reason. I don't want to give anybody the idea that kids like this are easy to raise. You hear people sometimes, you go on these discussion boards and people say things like, oh, all these kids need is just a little discipline. Like, well, yeah, try it, see how it works for you. It's an art form that we've had to develop over a long number of years. That being said, I'm gonna present Patrick and then have a kind of a question for you that I want you all to think about. So I'm going to start with Patrick's first hike. This is a story when Patrick was about 18 months old or so. We moved here to Portland, and Portland, of course, is an awesome hiking place. And we heard about Multnomah Falls, the largest waterfall in the world. And so we went out hiking. We hiked up top of Multnomah Falls, and then we got to the place where it got kind of flatter, and we put Patrick down on the ground. And he started to run as fast as he could go, uphill, down the trail, and every about, 200 yards or so, he would fall flat in his face, whack, right on the ground, hard. He didn't wince, he didn't cry, he hardly even dusted off his hands. He just stood up and he started running again, and he kept running and running and running. I'm guessing probably 2 miles before he finally tired out enough and wanted us to carry him again. So he's 18 months old, right? He didn't even walk that much, right? So that's what his first hike was like. So let's talk about what does that show. He's very hardworking. He's persistent. He doesn't give up just because there's a few bumps and bruises. He's athletic. Dang, he's athletic. He runs fast, too. Hard to keep up with him. He's pretty tough. He doesn't mind hitting the ground. He bounces off, He's independent. He's not worried about whether we're coming along with him. We'll catch up, right? He's courageous. He's not afraid of being out there in the lead by himself. He's enthusiastic, that's for sure. Single-minded. He knows what he's going to do. Those rocks and whatnot are just kind of minor distractions. And he's willing to tolerate some pain to accomplish his goals, right? So I would say these are all pretty good, strong things. These are positive things that you could say about this little kid. Would anybody argue with any of those, that he's not displaying those kinds of characteristics? So... Oh, and also, he lives in the moment. The fact that he fell down and hurt himself 20 seconds ago is very quickly forgotten. Yes?
And kids about that age, the 2 years, they always keep on running.
It is very common.
That's a common thing.
Very common.
He's just really good at it.
He was just faster and more
faster
willing
than
to...
his parents.
And not worried about whether he was going to fall down and get hurt.
No, they're not going to worry about that.
He just didn't care. Because he was going to hike. That was what he was doing. It was because he hadn't been on the ground before hiking, It was exciting. All right, so the rest of the story, Patrick's trip to Newberry's. So Jenny had Patrick in Newberry's, and she had written a check. And she didn't have a check card, and the guy wasn't going to take her check. And so...
How old is Patrick
Patrick
now?
was what? How old was he now?
About younger than that.
2 or
Oh,
something?
maybe he was 2.
Two and a half, something like that. All right, so he had a gigantic tantrum right there, fell down on the floor, was screaming, making all kinds of loud noises, which actually helped out because Tina was kind of like, I'm not leaving until you sign the check. And people were piling up behind and getting irritated and impatient. And so he continued his gigantic tantrum, screaming. And eventually the guy's like, fine, I'll take the check. And out they went. But, so here are some other characteristics about Patrick. He's intense. He's oppositional. He doesn't do something just because you told him to. He's pretty damn loud. He's not worried people are going to think that he's too loud. He can be very aggressive. He sometimes was physical. There were times when we had to had to take him into timeout. There was a point where he wouldn't do timeouts. He was 4 years old, 5 years old. And we had to carry him upstairs. He would kick, scream, and try to bite. We had to throw him into the room and lock the door, which I felt really bad about for a while because I thought, oh God, it's horrible. I'm locking his room. But if you came back 2 minutes later, he'd be singing in there and he's playing with his toys and everything. But he was not going to let you direct him to do anything. He's stubborn, man. He's not giving up. He's not going to do something just because you told him. Not particularly cooperative, very strong-willed. Got bored real easily. If something wasn't exciting, he wanted to do something else. He wasn't willing to tolerate something that was dull for very long. Demanding. He would hang on the refrigerator door and rock from side to side and go, want. That's his way of communicating. He wanted something to eat. And he wasn't really willing to wait very long for these things either. He also kind of ignored his bodily demands. He hated to sleep. The bathroom was a very last-minute thing, It's if you really, really have to go. Eating was also pretty inconvenient. He would try to avoid eating as long as he could because he'd be busy doing something. So he got very into whatever he was doing, but he also forgot about the fact that his body was even there. When you notice that with the running, he would fall down and hurt himself. He didn't care. There was one time he was walking, he was 8 or 9, walking down the street, and he ran into a telephone pole with his shoulder pretty hard, spun him all around like this, and he continues walking down the street. And I said, Patrick, you all right? He's like, what? I said, you just walked into a telephone pole. He's like, oh, yeah, I'm fine. That was 20 seconds ago. So this is a description of Patrick. This is kind of what he's like. And he was like that pretty much all through his childhood. It wasn't really anything that we did to particularly make him this way, although I will say we did do some things. We didn't do some things that we should have done that might have made it easier, which we'll talk more about later. But, so here's the question for you. Is there something wrong with him? Or is that just who he is? I'd be interested in hearing people's opinions based on what you heard so far. Is there something the matter with him? Is he diseased or disordered or malfunctioning in some way? Or
single digits.
Is he just a kid? What's that?
He's in the single digits of age.
In the single digits of age, yes.
So I don't know.
You don't know? Okay.
I don't know.
That's a good answer.
Because there are some children, some adults, who respond to, let's say, changes in their diet and behavior can settle down, or they have toxic levels of something and behavior can shift. So
that's right.
I don't know.
So you really don't know?
And this is the way he is.
It is for sure the way he is. Does anybody else have perspective on that? Yeah.
Yeah, my daughter, both my children came into our family through adoption, but my daughter was born in the Marshall Islands, which and our adoption social worker noticed a lot of children who were adopted from them had these ADHD symptoms. And one of the theories in this respect is that the Marshall Islands, which was geographically isolated for centuries upon centuries upon centuries, it was probably, in terms of evolution, functional in that particular society to be that way.
Right, and in fact, maybe the kinds of people who were out there paddling around in the canoes to get there were more adventurous kinds of people, right? Yes.
There's a book by Tom Hartman, who's normally a political commentator. I know he's come here. But he wrote about ADHD, and his theory is basically that people who are more quote-unquote normal are more farmer types, and people with ADHD are more hunter types, and that those traits serve you well. And
we're going to talk about that a little bit later. Yeah.
Well, I've actually never met anybody like Patrick. But I'm from a farm area of Chicago. Maybe they didn't have any hunters.
Well, what happens to a kid like this if they live in a farming community? How do they get through the day and there's no school or anything?
They start hunting.
Well,
you put them outside, and they run around. They climb on things. They climb trees. They climb over the fences. They, tease the horses or whatever they do. And, maybe the dog bites them, and they learn that teasing the dog isn't such a great idea. Maybe after 2 or 3 times, because pain isn't such a bad thing. Because it's kind of interesting to see what the dog can do. So they run around, they do things outside. And if you think about being in kind of a tribal society, this kind of a kid isn't going to create a lot of problems because they're going to have places that they can go, and it's sort of everybody keeps an eye on them, and as long as they don't get too far off to where the coyotes are, you're probably okay. And honestly, Patrick probably give a coyote a tough run for his money. All right, so
Steve.
Yes.
It's interesting to me that big word "wrong" there in that sentence was generated somehow out of the descriptions you put up there. That prompts the question: there's something wrong? Well, is that morally wrong, or?
Well, wrong however you want to interpret it. And that's actually a really, really good question that I'm going to put a little more nuance in a bit later. Because a lot of times we hear that this diagnostic scheme is a way of avoiding moral judgments about kids. We used to say the kids were stupid or whatever. Now we're just saying, oh, they have a disorder. But I think there's a kind of an implied moral judgment in looking at that behavior and saying there's something wrong with that. It's a lot of times framed as it's medically wrong, but is it really medical or is it something else? Is kind of what we're going to talk about as we go through here. All right, but he was a hell of a handful to raise. He was an arm load, right? He was not easy. I didn't really realize how hard he was until we had our second child. We were all steeled for the tough times, We're like, all right, we're going to be up in the middle of the night, and he's going to get up at 3 o'clock in the morning when it plays. He's going to have a giant tantrum and everything, and then we got Sean. And Sean was just the nicest kid in the world. I mean, he was unbelievably easy to deal with. I called him our mail order baby. If you had checked off all the things you wanted and sent to the mail order house for baby, that's what would come back to you. There was one point where he was, we were sleeping, and he woke up at 6 o'clock in the morning. Sean crawls into the bed, and he was two and a half. Yeah. So he wants to talk, and I said, Sean, it's too early. We're sleepy. I need you to go down to the bottom of the bed and play quietly for about an hour, and then I'll be ready to get up. He's like, okay. And he goes down to the bottom of the bed, and I swear to God, completely silent, like a puzzle head or something. And about a half hour later, he calls up, and he looks at me and says, is it an hour yet? I said, no. He's like, okay. And he goes back down to the bottom. Now, Patrick, he would have had his knees on my chest and peeling my eyelids open saying, come on, it's time to get up, right? So they're both very different. I mean, the genetic material can't be that different, for God's sakes. But they were radically different. I didn't really realize how hard Patrick was until we had Sean. I was like, wow, this is a totally different experience. All right, so moving along here. What is ADHD? I'm going to talk, this is what I'm going to talk about in the talk. How is it defined in the DSM? What does it really mean to have ADHD? Does standard treatment help, and in what ways? What are we trying to accomplish with treatment? Does stimulant treatment make a difference in the short term, in the long term? Because that's really when we say treatment. For the standard treatment is pretty much stimulants. Whoops. What did I just say there? Oh yeah,
and
what other alternatives do we have? And that's what I'm going to put at the end of the talk. So let's start with what is ADHD. ADHD has been around for a while. I'm going to talk about history, how it's defined in the DSM, and how do we decide if it's a disease. I'm also going to talk to them about genetic and imaging research, which is often used to justify the idea that it's a biological thing. We're going to talk about the question of whether genetically different is the same as being disordered or ill. And we're going to look at other possible causes. So let's start with this. The first kind of written observation about this was back in 1775, but it was framed pretty much as like a moral issue. Like these kids were unable to discipline themselves, and they didn't understand right from wrong, and it was the approach was kind of like they need to learn things that they're just not willing to learn. Then this British physician in 1902 again started talking about a defect of moral consciousness can't be accounted for by any fault of the environment. So, and look what he said here about moral control of behavior meant the control of action in conformity with the idea of the good of all. So he's definitely in a place of saying, like, these people don't understand what's good for everybody else. They're kind of selfish. They're not very easy. They don't control themselves very well. There was a big encephalitis epidemic in like 1911 and 12, and they saw that the consequences of this were some of these behaviors that we now call ADHD. And so they started to think maybe there was a biological reason why kids acted this way. And this guy Bradley tried benzodrine on these encephalitis victims and found that some of them, a lot of them, improved at least in terms of the adult's view of their behavior, right? So it was later postulated that children who had never had encephalitis had a similar kind of brain damage, but not as bad, which they called minimal brain damage. And this was what they talked about in the 60s a lot. It was considered a pretty rare phenomenon, and they used stimulants to try to treat this. But there was no test for it. There was no preceding encephalitis or any disease or anything. They're just saying, well, maybe because encephalitis led to this, maybe there's a problem in the brain that's leading to this. So that's kind of how the diagnosis got started. Today, there's about 11% diagnosis rate in the U.S., wild variations from 7% in Nevada to 13% in like Illinois and North Carolina and some places right through the Midwest and the South. For boys, the national rate is about 13%. Okay, and I wanted to create a bibliography list for you, but I didn't have time to do that. So anyway, this is from a Canadian government website. So I'm not making this stuff up. I'm not going to freako weird websites for this. This is all.
So 11% are diagnosed with that.
11% diagnosis rate in the United States, which is the highest anywhere in the world, by the way.
Of all
11% of all school-aged children over 1 in 10 has been diagnosed with ADHD as of right now. Boys, talking better than 1 in every 8 are diagnosed with this disorder, which is pretty big jump from back in the 60s where they're saying there may be a few cases where there's some kind of brain damage that we don't know how it occurred. Now we're saying 1/10 of all the kids in the country have some kind of brain damage. I think that's a pretty large leap that we're making there, okay? Okay, so this is the DSM-4 definition. I did that because I made it really small because there's so many of them there that it's just kind of ridiculous what steps you have to go through. But basically what you have is there's 3 different subcategories where you have to fit in. You have to show hyperactivity, impulsivity, and lack of attention, right? And some of the things that are in here are I find kind of funny. There are things like doesn't wait their turn in line, blurts out answers before the teacher is calling on you. There are behavioral things, though. There are things that sometimes has difficulty, or often, usually say often, has difficulty organizing things. That kind of stuff. So a lot of people don't realize that this is how you diagnose the stuff, that they think that there's some kind of test or something you can do to say, oh, well, your brain isn't working right. Well, there isn't. It is based on behavior alone. And there's a checklist, and you have to have 3 from column A, 2 from column B, 1 from column C. You can be diagnosed attention deficit disorder with hyperactivity, without hyperactivity, or primarily, what do they call it now? They say primarily inattentive and primarily, what's the other one? Primarily hyperactive type or something like that. Yeah?
Well, I know there is a test, I believe it's called the Connors, but it's based on teacher observation.
Right.
So, yeah.
Yeah, there are checklists that you can go through, and you can say, okay, does this happen? Never, seldom, often, always. And they'll have the teacher do that, they'll have the parent do that. They don't ask the child, of course. There is a requirement that it happen in more than one environment, so that you can't blame it just on the school environment, because you can have a bad teacher, the idea anyway, so you could have a bad teacher, a bad classroom environment that's creating this, so it has to be more than one environment. That is not always followed, however. Sometimes it is definitely diagnosed just on the basis of school behavior. All right, so I don't want to get any further into that. Anybody wants to look up those criteria can, but the point that I want to make is that these are subjective criteria, behavioral criteria, observed by an adult, not really consulted with the child, and it's not connected in any way specifically with any kind of physiological abnormality. There's no test you can do to say, oh, your serotonin levels, your dopamine levels are too low, you don't have enough dopamine receptors, therefore you have this thing. Okay? Questions on that?
It's like a conformity barometer.
That would be one way. Yeah, I would say ADHD, in a way, is kind of a list of anything that would get you in trouble in school. Pretty much. All right, so now we have to answer this philosophical question. And here's the other problem with how people talk about this. They talk about this as if we're all talking about science. But people forget that science is a subset of philosophy. And you can't really answer a scientific question unless when you have these philosophical questions that aren't answered. Like, is something a disease or not? Science can do that if you have criteria for what's a disease or not. But you have to decide what's a disease in order to be able to even make that scientific comparison. See what I'm saying? So you can't just say, oh, well, it's scientific because we did a test. You have to answer some of these key questions. So what is a disease, really? I looked it up in the dictionary. Any impairment of normal physiological function, and I put the emphasis on physiological, affecting all part of an organism, especially a specific pathological change caused by infection, stress, etc., producing characteristic symptoms. Illness or sickness and trial. So, as Harriet pointed out earlier, it is possible that this behavior could be due to a physiological problem. But as I just showed you, there's no requirement of that in those criteria. So what we may be doing here is lumping together people who really do have something physically wrong with them with kids who have nothing wrong with them at all, but just act like that. So a key question, right? Is he sick or is he not sick? All right, so apparently this also applies to plants, which I'm not going to get that interested in, but it also said any situation or condition likened to this, the disease of materialism. So if we're talking about that definition, a whole lot of things could be called diseases, right? To say, there's an epidemic of apathy in the political arena because people won't go vote, right? So that could be a metaphorical disease, and ADHD certainly fits that kind of a description. But as far as a medical disease, there's a physiological aspect to that really has not been answered. And it seems odd to me, and I don't know if it seems odd to you, but it seems odd to me that you would assume that all kids who behave this way, all of them did so for the exact same reason. That there was some physiological problem that caused them to do that. It seems like a pretty radical assumption to think that just because they act the same way, that it's going to be for the same reasons. Okay. So, related adjective, pathological, any deviation from a normal condition. And this is kind of the key point when you talk about psychiatric diagnosis in general, is there is this assumption that there's a normal condition. And there's a lot of assumptions about what a normal condition really looks like. So that was thanks to freedictionary.com. There was also a great, and again, I wish I'd written this up, and maybe I'll see if I can send this out on the email list, but there was a great article called What is the Disease that was on the, I can't remember what NCBI stands for, but again, it was a government website. And she just does a great job of looking at the philosophical question of how do you know if something is a disease or how do you decide that.
We can put these on the website, right?
Yeah, absolutely.
Okay.
So, does Patrick have a disease, given that definition? Is there something physically malfunctioning with him? You could test for that, One of the things that is commonly a problem for kids that have ADHD is they have difficulty sleeping. Anybody ever, gotten 2 or 3 hours of sleep and then had to go listen to a lecture or do something that was kind of boring? What do you do if you don't doze off? You need to keep from dozing off.
Fidgeting.
You gotta get your legs going a little bit, slap yourself in the face. If you stand up and move around a little bit, try to breathe a little deeply. Try to, do something to get yourself interested. You doodle, you take notes. You look around, try to find something to keep yourself awake, right? So you could have a sleep, not only not sleeping, but also a condition of sleep apnea is highly associated with having ADHD. Unfortunately, the stimulant treatment that is given for ADHD also causes insomnia in a lot of people. And so we sometimes run ourselves into a chicken and egg thing here where a person may be not having enough sleep and they're acting hyperactive and they get put on stimulants and they get even less sleep, which often means they get a sleeping medication as well. And I won't get into talking about how sleeping medications have their own set of issues.
Let me just comment on something.
Yeah.
One thing that I didn't realize until we had kids who were getting into their preteen years is that their school experience is very, very, very different from our school experience.
And how do you mean that?
And one of it specifically is just the enormous amount of homework that they have.
Yep.
Right.
And basically, their classmates, stay up, who are quote unquote normal, stay up until 10:30 doing their doing their homework, which alone doesn't lead to enough sufficient sleep time. And my children who stay up, my daughter who stays up later gets even less sleep, and so it's very hard to separate that lack of sleep and inattention to the true, if there's anything else that's going on.
Right. And remember what I said about Patrick. He didn't like to go to sleep anyways, right? So if he has an excuse to stay up late, he's not like, I got to get my homework done real quick so I can get sleep on time. Patrick used to be on the wrestling team in high school, and they would have wrestling meets that went from like 4 till like 9 p.m. So he'd come home 9:30, 10 o'clock, and he had 4 hours of homework to do. So he's not going to get enough sleep.
And just short comment. The kind of ironic is that because of the a lot of the changes in the school, some of their physical education period is done not by running around, but actually by looking at the history of soccer or something like that.
Right. Not to mention the cutting out of recess, which I could do a whole other lecture on how just incredibly stupid it is from an educational standpoint. And recess is very educational. Yes?
This might sound like it's a little bit off subject, but I'm not so sure. You mentioned apnea and association with AHEH, and there's different types of apnea. And for some people, they have what they call a small opening, and the doctor may say you got apnea, we'll put you on a machine, but in many cases, the small opening is caused from a narrow upper jaw, and some of the common symptoms are an elevated eye tooth, which means the jaw is too small, and the dentist will look at the mouth and say, no, your teeth are too big, we'll take out one. and so it doesn't really correct the problem. The correct procedure is to tie a wire from the first bicuspid on one side underneath the roof of the mouth to the first bicuspid of the other. And they have a screw, and you turn it every day.
So like
it can only be done in men until the age of, the best time to do it is 11 years old, because that's when the body's growing the fastest. I just thought I'd throw that out.
Well, and again, what that goes to show you is there could be a lot of reasons why this stuff is happening, and there's no attempt in the diagnosis of ADHD to distinguish what it is that's going on that makes it happen. It's just like if you act this way, you get the diagnosis. And I can tell you that most psychiatrists do not know anything about sleep apnea or jaw size or any of that kind of stuff.
If you don't get it fixed with rapid palatal expansion, which is a non-surgical procedure, and you don't do it, when you're young, then the only way to fix it is to break the jaw.
All right. We can't go there. All right. Secondly, is there a known cause? Is there something making this happen that makes it treatable? Like if you said, okay, this happened because this child was exposed to alcohol prenatally. This is why we're seeing this kind of behavior, and we see it in other kids who are exposed to alcohol prenatally. We have a cause-effect relationship. We have a set of symptoms that occur together. We can kind of look at that group and say, well, what can we do that's going to help them, and figure that there are probably going to be some similar things that you can do. This group is not homogeneous in that way. It's pretty heterogeneous. So I don't know if there's anything wrong with them or not. The other thing that's important is, can this condition be reliably and objectively distinguished from others with similar symptoms? Can you say, I know that this is this particular problem because of this and this and this test? Like if you had, let's say you have rheumatoid arthritis, right? There's testing you can do to show that there's this bug in there that's causing your arthritis pain. Or, if you have diabetes, you can test blood sugar levels. There's a way that you can say, okay, I can say this person who is overweight and has swollen feet and has circulation problems has diabetes. This person has congestive heart failure. I can tell them apart from each other, right? All right. Oh, and let's talk about rashes. I love that example. So, hey, Sarah. So, is a rash a disease? Y'all think a rash is a disease or not?
No.
Why is a rash not a disease? It's a symptom, maybe. Why is a rash not a disease?
It's a symptom.
Because it can have multiple causes, right? You can't identify one cause. So, and that also means there's not one treatment. So if you have poison ivy and you have a rash, you can put calamine lotion on it to stop it itching, and it's going to go away. If you have syphilis, you can put calamine lotion on it, and it's going to go away. And a year or two down the road, your brain is going to be deteriorating, and you're going to become mentally incapable. You want to really know whether it's poison ivy or syphilis, right? You don't want to just treat a rash as if a rash is the thing you're treating. A rash is an indication that there may be something wrong. And that's kind of how I look at ADHD. It's an indication of something, maybe not. And that something that may be wrong could be physiological. It could also be sociological. It could be having to do with your educational environment. It could be having to do with what's going on at home. There's a lot of reasons that could be making this happen. And it could just be because that's the way you are. And there's nothing wrong with you at all. So, does this behavior fall outside the realm of normal for male children of his age? What do you think? How, there's kind of like a bell curve, right? Here, like the bell curve. That, here's kids who are sort of average activity level, here's our low activity kids, here's our high activity kids. How far down here do you got to be before you're outside that range of normal? I mean, anybody study statistics? How far are you supposed to be beyond that?
2 standard
deviations. It's kind of like, way out here at the end somewhere, right? So, they don't apply that statistical analysis to the kids that they're seeing in the clinic, right? So we started out when we were talking about MBD, we were way down here at the end where there's just like this little tail of people. But because there is this vagueness to the criteria, this line starts moving and moving and moving and moving and moving. And now we're at the point where 10% is definitely less than 2 standard deviations away from the mean.
Definitely. Profits.
Especially for boys. It's definitely way less than 2 standard deviations away. 13% of boys are being diagnosed. So there's a whole bunch of people in here who are actually pretty normal. There's nothing wrong with them at all. They're just kids who are acting like kids. And we don't like it because it's irritating. It's hard work. I can tell you that. Anybody think of any other criteria for a disease besides what we talked about? I kind of like this.
Well, yeah.
Yeah, what?
There's nothing there about infections and agents that get in your body and create havoc and stay there and so on.
Yeah, that kind of fits into the identifiable cause thing, right? Yeah. If I have a fever because I have a germ floating around at me, I know what's wrong, and I know how that kind of works. It's probably going to go away after a little while. I don't have to particularly do treatment, but if I start wheezing and my lungs feel really tight, maybe I have pneumonia and I need to get an antibiotic or something. Carlo? Yes.
So are you saying that list that was just up there is a set of criteria that you can use to define whether or determine whether or not a disease exists?
I'm not saying that I have the answer to that question. I'm saying is that question has to be asked. And I'm using kind of what most people sort of think of when they think of a disease in our culture. And what I'm kind of saying is the term disease is now starting to be co-opted and used for conditions that we merely find difficult or annoying to handle, because we're not really being careful to say what do we mean when we say they have a disease. And that carelessness and that subjectivity allows that line to be moving over based on, because part of the deal too is the kids are the ones being diagnosed, but they have no power or say-so over this at all, generally speaking. Nobody asks them, how do you feel about your school behavior? I shouldn't say nobody. There are some people, I'm sure Carl would do this. I am sure that Harriet would do this too. But there are a lot of kids that don't even get consulted about whether or not they have anything wrong with them. They just are diagnosed by another person looking at them and checking off checklists. So they have nothing to say about it, and I think it makes it all the more easy to move that line when you don't have feedback from the consumer, as it were. Carlo?
I just wanted to mention that a lot of the biological markers that we might have looked at have been really very hard to get to until now, because we got the blood-brain barrier and we didn't have. So now there are imaging techniques, which I guess you're going to talk about, Now, we're beginning to look at genetics and chemistry and different ways, organic acids and neurotransmitters that we haven't looked at before. But I think that still begs the question because, you know, if you measure all of us, we're all going to have a range of something going on.
Right. Yeah.
So, and the question is, you know, where does it cross the line that, oh, well, we have to really make a serious intervention here, which might compromise their health, compromise their freedom, compromise all kinds of things. Where is the place that you say it's not a characteristic, it's a pathology?
Right. And that is leading right into where I'm going to go next. Yes.
You know, sometimes when I've seen the kids like that who are getting in trouble, if you look at the dad, it's just an older version.
Yeah, it's true.
If you look at the dad, it's an older version.
It's true. I mean, a lot of these are characteristics of masculinity, to be honest with you.
Well, I mean, and the dad has been successful without any.
Yeah. He's figured out a way to do it.
Yeah.
So, what about these brain scans? You see these pretty pictures that say, oh, here's the ADHD brain, here's the other brain. I think this guy, Keith McBurnett, put it down really well. He said, the problem with relying on any single test is that while on average kids with ADHD may show differences in their brain scans, he's talking about, but these differences emerge from group averages and don't always show up in every individual case. Mm-hmm. So those pictures you see are not, this person has this brain scan, and we did another one, and this person has this brain scan. They average them over a large number, and they say, oh, well, there's a tendency of people with this ADHD diagnosis to have a brain that looks like this. Now, it may be that that's suggestive that a certain subset of these people do have something wrong with their brain, but we're not able to say that. We don't really know that. The other thing is that these scans, the PET scans in particular, are looking at how the brain is being used, not structural stuff at all. So it may be that a certain brain scan pattern is associated with being bored, you know, and so, or being frustrated with a certain situation. So maybe you put the ADHD kid and have him try to do some test where he has to really focus attention, and he gets annoyed and irritated, and his brain goes like that. Maybe I would do the same thing if I was doing art, because I don't like doing art. I feel really inadequate. I'm sure some part of my brain shuts down when I start doing art because I feel like I'm not going to be successful at it. So I'm not saying that's what's happening. I'm saying there's a lot of variables here that need to be looked at, and you can't just say because this brain is different, that means that there's something wrong. It's how the brain's being used at a particular time. Okay, so also Daniel Amen, who's like the guru of brain scans, he says low activity in the prefrontal cortex, low activity, remember now, not structural problem, low activity, is typical of ADD, he says, but it can also occur with schizophrenia, dementia, and head injury. So you can't use a brain scan that could indicate 4 or 5 different possible issues and say, that's going to tell you have ADHD. Yes?
And it could also occur with somebody who's entirely normal.
Exactly. Yeah, I won't go into that, I don't have time for that. MRI studies. MRI does look at structure, and they show that there are some changes in the brains, differences in the brains, again, on the average of kids who have ADHD. The changes were pretty small and varied from case to case, and the changes did not actually correlate with a set of symptoms. Like a person who had a smaller caudate nucleus, I think was one of them, didn't necessarily have more symptoms of ADHD than somebody who had a larger one. So there wasn't a direct correlation between these things. And they also very rarely control for stimulant use. So some of the brain changes may be caused by stimulants, because we know that stimulants do cause changes in brain size.
Wow. So you're saying that the drug that they actually are using for it may be the cause for some of the structural brain changes.
Right. There's really any of these drugs that you use that are affecting a neurotransmitter, like the clearest example is with psychosis. If you use antipsychotic drugs, they decrease the amount of dopamine production and uptake in the brain. And after you do that for a while, you see the actual white and gray matter shrinking, especially in the basal ganglia, where there's a lot of dopamine receptors. So over time, it's not like it instantly happens, but over time, if you keep using these things, there can be, in some people, some changes in the brain.
Has anyone ever done a study of the people who are prescribing the medications to see how their brain reacts to those who have this symptom versus those
I
who
would love
don't?
to see that study
And
done.
whether
That
or
would be
not
interesting.
their annoyance at this caused them to prescribe the drug as crowd control rather than. No, I mean, I think
There was
it's a fair thing.
I think it is, absolutely. There was actually a pretty funny story of this guy, doctor who worked with kids that most of them went to the same school, and he kept getting notes from the same teacher saying this child needs to be on, this child needs to be on, this child needs to be on. So finally he wrote back to the teacher and said, John is actually completely normal. However, if you are interested in getting some medication to deal with your apparent anxiety and dealing with these kids, you're welcome to come by.
Well, I actually was at a program around differences in what's it called? How kids are punished.
Right.
In school, differential punishments
Right.
for, in particular, African American kids
Right.
and I think other kids of color.
Right.
And there was a story about how this one teacher, like so many of this teacher's kids, kept getting sent to the principal and had to do detention and everything.
Mm-hmm.
And they created this intervention. They said, well, if this many of the kids in the school are needing interventions,
Right.
maybe it's the environment, maybe we could teach
Yeah.
teachers. And so they focused on this one teacher because she had the highest
Yeah.
referral rate, and they went and they taught her some basic skills of how to be more respectful and effective, and she didn't have one referral
Wow.
next year.
Wow.
None at
That's
all. Wow.
amazing.
Because
Yeah.
of a very compassionate intervention with
Right.
the kids' environment.
Teacher. Yeah.
Yeah, and I think that's important too, because a lot of things I'm going to state later are things that we kind of discovered through research and our own experimentation, but these were not things that were necessarily readily available. And a lot of teachers don't know anything about this stuff. In fact, I went to education school, and they didn't teach me a damn thing about behavior management. I mean, nothing. Other than, punish kids who do bad things. That's kind of it. All right, so I'm going to have to pick up my pace a little bit here. There were also genetic studies done. And this has been like the holy grail they've been seeking for years. Probably, since the 60s or before. There is no consistent evidence of any specific genetic pattern in ADHD children or adults. They will identify, this particular gene can be associated with a certain number of cases, and this particular can be associated with a certain number of cases, but the total number of cases is relatively small. And there is no clear pattern that you can say everybody has a problem with dopamine production or dopamine reception, or this particular gene, or this particular set of genes. It's kind of scattered.
Is there a genetic predisposition? I mean, if your parents or your grandparents had...
The answer is we don't know that for sure. They've done twin studies that suggest there probably is some level of heritability, but again, people who speak Chinese give birth to children who speak Chinese too, so there's an environmental factor that has to come into play too. My opinion is there probably is some, but there really isn't a clear record that shows that there is an actual genetic set of things that come across. I think what people who would probably say now is it's very, very complex. There's probably a combination of different things that interact with each other to create this kind of behavior, and it's not the same combination for any two people necessarily. So similarly, despite identification of several candidate genes, none of them seems to have a substantial effect, and the exact etiology underlying ADHD has remained elusive. So again, there's some effects on some individuals, but as a group, this guy Wallace et al. Did a review of all the genetics, and that's what he concluded in 2008. All right, so here's a good question. Does a genetic difference equal a disorder? There is, everything I'm saying to you in the next couple minutes here is going to be absolutely 100% scientifically true. And I'm going to help you talk about a group of people, and if somebody figures out who this group of people is, you have to not share it. So it'll take some of the fun out of this, all right? There is a very specific genetic aberration which is associated with the following. 98.1% of rapes are committed by people who have this particular genetic arrangement. 90% or more of domestic abuse is committed by such people. 90% of homicides are committed by these people. 90% of incarcerated criminals have this genetic pattern. Okay, somebody's figured it out. Yeah. These people are physiologically differentiated from the general population. They're abnormally large and heavy, excessive body hair, 4 to 10 times the level of a certain important neurochemical. It's known particularly to increase aggression. Genetic structure is observably different under a microscope. Even a 9th grade biology student would be able to tell there's something wrong with this cell. There's something different about this. Okay? So all this is true. So here's the question. There's 3 treatment options. First, there's drug treatment to reduce the excess neurochemical and also reduces the physical and sexual aggression. Okay? There's surgery that can remove part or all of the offending glands that excrete this chemical. And due to the availability of simple genetic testing, prenatal counseling can be provided. What's your solution here? What should you do?
When in doubt, cut it out.
Does anybody not know what group of people I'm talking about here? All right, who knows who this group of people is?
Y chromosome.
Yeah, Y chromosome.
What's that?
Gender.
XY chromosome.
Males, right. We're talking about men. Everything I said is true about men. Men are genetically different. They have very different biology. They are more aggressive. They're hairier. They're lumpier. They're more muscular. They tend to commit more crimes. They obviously have a disease, right? It's genetically founded. There's genetic difference. Testosterone poisoning is clearly the cause of masculinity. And interestingly, too, if you take a male, an XY baby, and you protect it from testosterone, it develops into a female. And if you take a female embryo and expose it to a whole lot of testosterone, it develops male characteristics. So obviously, men are an aberration, right? I mean, you women already knew that, right? So the reason I say this is, it's pretty easy to go down this pathway of saying, well, these people are genetically different, and they create trouble, so they have a problem that we need to create a medical treatment for. Why is it that men have these differences? Why do they exist? Why are men so different than women?
Hunter.
Yeah, they needed to do different things, right? Men needed to go out and run and throw things and, wrestle bears to the ground or whatever, protect against other people coming to attack your village. And what did women have to do?
Get the water.
Women have to give
everything
birth.
else.
Right? Women have to give birth. Exactly. Even if women are really good at throwing spears and running and everything, if they can't give birth, their genes don't pass on, right? So men are going to be selected for being able to be big and strong and fast and be able to kill things, whereas women are going to be selected for the ability to give birth, because otherwise they don't pass their genes on, right? So, point being, genetic differences are important to species survival, right? We have to have genetic differences. All right, some other causes. There's a list of 50 possibilities. If you just put in 50 conditions that mimic ADHD, you can see them. Some of them are pretty rare. I'll give you a few highlights here. Boredom. Being in a classroom where you are not challenged. I certainly was in those kind of classrooms, and I was not an actor out, I was an actor in. But oh my God, there were times when I just wanted to slash my wrists or put my eye out with a fork. It was so dull being in those classes. Mm-hmm. It was horrible, right? So if I had had an ADHD type of personality, rather than holding all of that in and hating myself and wanting to jump out the window, I probably would have gotten into trouble. But I didn't here. Anxiety and depression. If you look especially at the symptoms of anxiety, there's a huge overlap with ADHD. And why would that be? Why would an anxious person be kind of acting fidgety and whatnot? Why would that be helpful if you were anxious, do you think?
Distracted.
Yeah, you're trying to distract yourself from your inner feelings. If you got something going on out there that can keep you busy, you don't have to think about whether your mother's going to get killed tonight before you get home. So anxiety is definitely an overlap there. Low iron or anemia is highly associated with these exact same symptoms. Thyroid problems, sleep apnea we talked about, or lack of sleep. Fetal alcohol syndrome. I work with foster kids. I work with the COS program actually that Jen was in. And I have seen, probably hundreds of kids, at least dozens of kids that have had fetal alcohol syndrome. I have never seen one yet that didn't get diagnosed with ADHD first. They always do. The same with kids who have really serious attachment problems. They almost always get diagnosed with ADHD. Now, kind of apologists for the ADHD diagnosis will say, well, they don't really have ADHD. They have this other thing. If there's another cause, then it's not ADHD. But how would you be able to distinguish that from the checklist? You can't. So unless you get somebody who's sharp enough to say, hey, wait a minute, did her mom have drinking problems before she was born? Maybe we should look into that. Unless somebody asks that question, there's nothing in the screening that says check for fetal alcohol syndrome. Yeah.
I wanted to say something about the fetal alcohol. Would it also be that maybe they don't diagnose the fetal alcohol because that also places blame on the family?
That can be.
And then as far as the sensory. Sensory was the other thing because my baby was diagnosed with sensory processing and anxiety. And I was told in another workshop that I went to that as they get older, they get diagnosed with the ADHD because the sensory processing is not recognized.
Right.
And, which I think is probably tied to prescription.
Right. Yeah. Well, and sensory processing issues are often attached to prenatal drug or alcohol abuse or early childhood neglect, abandonment, lack of stimulation when you're young. That's another one that's on the list, is sensory processing problems. But I think there is a reluctance to put blame on a parent. And I think the other thing about it, if you do something like fetal alcohol syndrome rather than ADHD, is you got to do something about it. It's work, man. The cure for fetal alcohol syndrome, there's no cure. But what you're supposed to do is make environmental accommodations. You're supposed to change your classroom so that it's going to work for this kid. Well, that's a lot of work, right? It's a lot easier to say, oh, well, let's just try them on this medication and maybe they won't be a problem anymore. There's actually an interesting study done back in the 70s when they still had studies that were funded by non-drug companies. They looked at kids who got stimulants versus those that didn't, and they looked at the amount of teacher attention that they got. And they found that the kids, I'm talking about help, like teacher help, not attention for being bad, but the kids who got the stimulants suddenly got a whole lot less attention from the teachers because the teachers felt the problem has been solved. Yeah. All right, so
how about
this,
like ingestion of caffeine or high sugar?
There is a short-term effect of sugar. It doesn't really cause long-term kind of things.
Caffeine?
But there is caffeine is a stimulant and theoretically should make them actually more tractable. I don't know any studies on that though. Child abuse, domestic violence at home. Again, people say, "Oh, well, this doesn't cause ADHD," but it causes the exact symptoms of ADHD. And what will happen is we'll say, "Well, this kid has ADHD." I said I work with foster kids. They get the ADHD diagnosis like 4 to 5 times higher than the general population. You'll have 20% sometimes of the kids will have an ADHD diagnosis at a certain age. And they had child abuse and domestic violence going on at home. Well, why is it so much higher? There's actually people who are so disingenuous as to say, well, that's because ADHD kids are more difficult to manage and it's more likely that people will abuse them, which I just think is so horribly insulting. It does cause these kinds of symptoms if you have an unstable home life. And you can't just say, oh, well, that doesn't count because there's another reason. Inappropriate developmental expectations are also a big problem. That somebody was talking earlier about the homework, right? If you take a 4th grader and give them 4 hours of homework at night, you're going to run into some problems with some of them. Some of the 4th graders, will soldier through and do it, and some of them are going to be like, screw this, man. This is too boring. I can't do it.
Even just things like major changes, a lot of major changes, it doesn't have to be
abuse, right?
Yeah.
Yeah, any kind of high levels of stress can cause people to act out in these ways. And not everybody will do it, and that's the other thing I'll tell you as well. Not everybody acts that way, so there must be something about you that means you act this way versus being depressed or anxious or whatever. And I don't really buy that. It's kind of like, if you weren't that way before the stressor and the stressor made you that way, you're trying to cope with stress. It's not a disease. It's an attempt to cope with a difficult environment. All right, so this is a good example of the developmental problem. Morrow et al. In 2012 looked at Canadian children starting based on the age that they started kindergarten. Apparently they break it off in December. So if you're like born in January, they move you a year earlier. Mm-hmm. So they looked at kids that were born in December who went to school a year younger, and kids that were born in January. They compared them, and they found starting 1 year younger led to a 30% higher likelihood of ADHD diagnosis. So fully a third of your ADHD cases will go away if you just wait a year to send the kid to school. That's inappropriate developmental expectations, and a 41% higher likelihood of stimulant prescription. And they said that previous U.S. studies have showed similar findings. Again, this is in pediatrics, right? This is not a wild, out there kind of a journal. This is a mainstream kind of a journal that's talking about this stuff. So this is real. And I don't know if you guys remember being in kindergarten, but I do. When I was in kindergarten, we played with finger paints, right? We sang the ABC song. We maybe learned to write some letters and stuff. There was no homework. There weren't like a bunch of worksheets and stuff. It was mostly playing, right? I mean, am I wrong? Look at what they do today in kindergarten for kids. They expect kids to learn how to read before the end of kindergarten. Well, in France, they don't even start them in school until they're 7 years old.
Yep.
And yet the French high school students do much better than the U.S. high school students do in terms of math and reading and all this kind of measures, right? So obviously forcing kids to start to learn to read when they're 5 isn't sensible. Most of them aren't ready. Or a lot of them aren't ready. Now, some of them are ready, and they should be able to read if they want to. That's the other thing, is if you get ahead, then they get upset with you too, because then you're going to be bored. I used to tell parents back in the 60s, so don't read to your kids at home, because then they're going to get ahead, and then they'll be bored in school. That's going to be a problem for me. So, this is kind of pointing to where I think a lot of the problem is the structure of the school and the expectations that we have of kids are not actually appropriate developmentally. And we ask things of them much too young, and then when they don't do them, we get upset with them. And some kids are tough, and they will, like I was, I would just hang in there and I would keep working because I wanted to get approval, or I didn't want to get in trouble at least. But I was bored out of my freaking gourd, right? And there was a lot of things that I could have done that would have been a lot more educational and fun for me. I happened to be one that didn't act out, but I wasn't getting any more out of it than probably those kids who were sent to the principal's office, honestly.
Even not doing looking at kids at kind of our sense, if you look at the preschool children that are allowed to read when they're ready or want to, once they learn to read, it's like boom.
Very quick.
Take off.
Yep, it's true. And when you look at test scores for those kind of schools versus regular schools, when you look at like 4th grade test scores, the kids in the standard school do better. But when you get up to 7th grade, they're definitely caught up. And when you get up to like 8th, 9th, 10th grade, they are ahead of the kids who learn in the standard way, in general.
And the college scouts look for them because there's a whole other level of developmental and curiosity and learning skills.
Yeah, they love them because they are self-motivated learners.
Right.
They're there because they want to know things. All right, hunter or farmer, we talked about this a little bit already, but I was talking about... So what are we trying to accomplish here? There are many causes, we talked about that, but there's also 2 possible goals. One is to improve educational and social outcomes. The other is to improve behavioral compliance and reduce conflict. I try to focus on the first one. But a lot of times, teachers are overburdened, and again, as somebody pointed out, they don't necessarily have the skills, and they tend to focus on the second. And parents also, too, because these kids are hard to manage. They're difficult. All right, so I'm going to have to whip through this pretty fast. Come on. Talk to me. Okay, so short-term stimulant treatment. Stimulants are very good at reducing short-term hyperactive inattention systems. They work really well. About 70-80% of people, Chad says 85, but they're kind of paid for by the drug companies, so they're inflating a little bit there.
I mean, that's the whole problem right there. I mean, you've got, the whole thing is manipulated by drug companies.
Yeah. Well, I don't think it's the whole problem. I think it's a big part of the problem. The Australian site that I looked at said 60 to 75%. I think that's probably a pretty good estimate right there, of kids will actually improve when they take the stimulants in the short term. So that means they're going to reduce their hyperactivity, reduce their impulsive actions, they won't call out in class much, and they will pay more attention to things that they might normally find dull. There's a lot of talk about this paradoxical effect. I don't know what that means. That ADHD kids somehow react differently to stimulants than normal kids, and that's how you tell if they have it. Total bunko. This was debunked back in 1978 by Judith Rappaport, who gave stimulants to normal high school teenagers and found exactly the same kinds of things, that there would be less motor activity, there would be more focus on a particular task, they'd be harder to distract. She said that the reason why it's considered treatment for the ADHD kids is because that's what people are looking for, that's what they're wanting, whereas the normal kid, they don't care if they're less active because they're not a problem. So there really is no paradoxical effect. There are side effects including sleep loss, affective depression, irritability, aggression. This one I think is the one that disturbs me the most, especially what I see in foster kids who have anxiety problems or attachment problems. They don't have such good control of their aggression anyway. And if you give them a stimulant, you're cranking up their dopamine levels and they may become more aggressive. And instead of the doctor saying, oh wait, we just increased their dopamine, they become more aggressive, there's probably a connection there. A lot of times they get diagnosed with bipolar disorder, and then they get put on Abilify, which has a dampening effect on the same dopamine that you're increasing with the stimulant. So to me, that's just totally crazy. You're increasing dopamine with one drug, decreasing it with the other one, because you did too much increase. Doesn't make sense. So anyway, you see a kid that has ADHD and bipolar disorder, you automatically just need to be suspicious. When did that bipolar disorder thing start? Was it before or after you gave them the stimulants? So in somewhere around 80-90% experience unwanted side effects. Long-term outcomes. Here are the consequences of untreated ADHD, according to a source online. Lower educational attainment, difficulty maintaining employment, more likely to be divorced, increased interpersonal problems, twice as likely to smoke cigarettes, twice as likely to abuse alcohol, more likely to suffer from anxiety, depression. Sounds bad, right? So that's what happens with untreated ADHD. And then anytime you hear somebody kind of pitching why your kid should be on medication, anybody as a parent hear that pitch to them about why their kid should be put on medication because of all these possible long-term outcomes? Anybody? Okay. Well, this is kind of what they tell people, is to say, well, you don't want your kid to turn into a delinquent, right? You're going to increase the chance of delinquency. One problem, however, none of those consequences, not a single one on that list, is improved by stimulant treatment. None of them. Zero. Okay? I should be fair. Probably the one about accidents, there's somewhat of an improvement. That's the only one that there really is less accidents. But other than that, stimulants don't change any of that.
Treatment of ADHD.
Yes. I'm saying kids diagnosed with ADHD, they compare kids who stayed on stimulants versus ones who got ADHD and were not treated with stimulants. No difference in the long run. Let me show you some studies. There's literature review first done in 1978 by Barkley and Cunningham. Russell Barkley, yes, the same Russell Barkley, who claimed that not medicating your child with ADHD was child abuse. I've never quite forgiven him for that, because he called me a child abuser. But he, and he's a big ADHD guru, sells books about it, goes and gives talks. He, in Cunningham, found in 1978 no lasting positive effects on academic performance from stimulant use. Swanson, in 1983, no improvement in academic skills, athletic skills, social skills, antisocial behavior, or arrest rates. These are all the things that you would want to improve, right? None of them got better. None. OSU, Oregon State, Drug Effectiveness Project. This is about 2004, 3, somewhere back there. Good quality evidence is lacking that ADHD drugs improve global academic performance, consequences of risky behavior, social achievements, and any other measure. So that's 3 separate reviews, and these guys looked at 2,287 studies. They looked like every study you could possibly find on the subject. And they're saying there is no quality evidence that any of this is improved.
Is that what you call a meta-study?
Mm-hmm. Yeah.
It's a systematic review. A
Okay.
meta-study is
So, the MTA. Now, it's not a meta review. Right? Stimulant users. This is the MTA study that you've heard about. This got big press. Stimulant users had better symptom control at 14 months, improved reading scores 14 months. But all those advantages were gone at the 3 and 8 year follow-ups. this is the good news. Most of the kids continue to have sustained improvement regardless of whether they took medication or didn't take medication. But when that 1 year, the 14-month stuff came out, there was this big national, international announcement like, now we have proof that ADHD, that stimulants improve ADHD over the long term. And the reading scores were not improved that much, by the way. But all that stuff went away by 3 years.
Hey Steve, what is MTA?
MTA, I can't remember what it stands for, multimodal treatment, something thing. And there were no difference between stimulant and non-stimulant groups. I don't know why this is going off the bottom of my screen here.
But weren't there a lot of physical, physiological harm done to those that was kept on the drug, like sleeping less and?
They had for sure they had growth retardation. The kids that used the stimulants over time had significantly lower height and weight than the ones who did not. That's the only negative measure that they found.
Almost like they're trying to stimulate them to grow faster and develop faster than they naturally do, and it just throws off the whole developmental growth timeline.
Peter Brain talks about that a bunch, where he said it's not just that they're shorter. There's other aspects of growth that are not visible from the outside. There's organ development, brain development, liver, heart development, all those kind of things. If you're not growing, are all going to be affected. Puberty can be affected. So, growth retardation isn't like a minor issue. All right, the RAIN study was done in 2010 in Australia, or was finished in 2010, reported on. They compared, again, stimulant-treated ADHD-diagnosed kids to those that were not. They found no significant differences in depression, self-esteem, or social functioning. Stimulant users were 10 times more likely to perform below grade level according to their teacher's rating, which I found kind of shocking. Stimulant users also had elevated diastolic blood pressure. And their quote was, the results seem to indicate there's little long-term benefit of stimulant medication in the core symptoms of ADHD. Now, I'm saying core symptoms. That's not even outcomes I'm talking about. They're saying these kids were not less hyperactive, not less inattentive, not less distractible when they had long-term stimulant treatment. So stimulants, what's the picture emerging here? Stimulants are a short-term intervention. They work for a little while, and then they stop working. So you need to be doing some other stuff, not just stimulants. 2013, 4,000 children in Quebec studied over 11 years. Findings were ADHD boys treated with stimulants performed worse in math than the non-treated in the short and long term, and were more likely to repeat a grade, which kind of fits with the Australian study. Girls receiving treatment were more likely to have psychological problems like anxiety and depression, which are side effects of medication, but also may indicate that they're getting the diagnosis because they have some other psychological issues that need to be looked at.
Do they factor control for the possibility that those receiving treatment had more severe symptoms, which is why they were given medication?
The MTA study was randomized. The other two were naturalistic studies, where they just were looking at, did the ones who get stimulants do better than the ones that weren't. So it's hard to do a long-term, like an 11, 12-year study in a controlled condition. But it's also true that that's the conditions that people are exposed to in the real world. I think it's very, very significant when we're talking about millions of kids being put on stimulants that we're seeing in the collective, they're not getting any better outcomes. So we're exposing them to some pretty significant risks of harm without any improvement in outcomes. So that leads to the next question. Well, if that's not improving long-term outcomes, what should we do? And this is the fun part, I think. Now we meet Kevin. Kevin's our youngest. In addition to all the exact same things that Patrick displayed, some of these are overlaps. He's very, very smart, very athletically gifted. He loved to climb. We used to have keep our telephone up on top of our upright piano. Not a spinner, it's a full upright piano, probably 6 feet off the ground, because Kevin would play with telephone. So at one point, he managed to climb up onto there. It was like, 13 months or something like that. Climbs up, picks up the telephone, get it away from him, hang it up. Seconds later, get a call back. Hello, this is 911. Is there an emergency? He said, no, I'm sorry. My son got hold of the phone. They said, well, you should put it up somewhere where he can't get a hold of it. Well, am I supposed to nail it to the ceiling? How much higher can we go? I guess I could have gone on the top of the refrigerator maybe. That was about it. So he was very talented at climbing. He got into stuff. And he wasn't being troublesome, he wasn't being difficult. He just thought it was fun and interesting to climb up in things. Moved very, very quickly, hard to keep up with. He was very oppositional and argumentative. He hated sleeping. Both Patrick and Kevin at one time said, why do we have to sleep? It's so boring. That's true. Both of them still don't like to sleep. There were some friends who wouldn't watch him because he was too difficult for them to manage. And his nickname was Wild Boy. So that's Kevin as a toddler. Kevin today graduated high school last year with a 4.0 GPA. All-state soccer player. He is now attending Evergreen State College. Never involved with drugs, crime, all those things that they warn you about are supposed to happen. Lots of friends and social groups. Very happy and confident about himself. No medication at any time. No particular diagnosis or treatment at any time. And you certainly know all the criteria when he was young. He was crazy wild. So what did we do? First one, this is, I think, possibly the most important thing. Alternative schooling. This guy, Peter Gray, is a psychologist. He did a qualitative study, which meant he just interviewed people about their experience with kids in alternative schools and homeschooling, which is in Psychology Today. And he found that the kids who were homeschooled or were in alternative schools generally did not get on medication at any time, and that it wasn't really a problem. That they had less behavioral problems, less of the symptoms of ADHD, and that they tended to be successful in that environment. Flynn and Rappaport in 1976 did symptom comparisons of kids in open classroom at the beginning and the end of a year that they had transferred. You know what an open classroom is? Everybody have an idea what that would be? No. It's like you have like workstations, like Montessori. Anybody know what Montessori is? It's kind of like that, right? You have workstations where there's certain tasks that you can do, but you get to decide where you go, when you're starting, when you're finished, right? So you have a lot more choices, and when you're at the station, you have more options of what you do first and how long you stay on a particular task. So they said those kids' symptoms improved a year later without any medication. Jacob and friends in 1978 set up a very good controlled experiment where they had kids who were matched by age, gender, socioeconomics, race, all the things that you could have as variables that you could think of. Put some of them in a regular classroom, traditional classroom, and some of them in an open classroom, and had teachers go in with this assessment tool and try to distinguish who was the ADHD child. In the regular classroom, they were like 90% accurate. In the open classroom, they could not distinguish between the ADHD kids and the so-called normal kids. So this should raise a question in everybody's mind here. Why don't we have these things? Why aren't we creating these situations for kids who have difficulties paying attention in the regular classroom? It's a very viable solution. Nobody ever quotes those things, by the way. I tell people about these. Nobody knows about this. The other big thing that we did was we used some creative behavior management. I was very fortunate to get a job at Edgefield Children's Center working with emotionally disturbed kids when Patrick was about 5. And I learned a lot there about behavior management. I also learned that standard behavior management stuff doesn't always work the same way for kids like this. And the story I like to tell is that Ginny, my wife, right here, had volunteered to do childcare while I was doing a parenting class after school. And so all the parents came with us, and the kids did that with her. Well, this one time, she was supposed to have an assistant. The assistant didn't show up. She had every single kid that came, and it was like, 11, 12, 13 kids, something like that. Yeah. Over 10 kids. And like 11 or 12 kids are there. All emotionally disturbed kids. And Patrick. So we go in, and we're like, do you need help? Can somebody stay? She's like, no, I got it. So we go in, we do our parenting presentation. 2 hours later, we come out. All 12 or so of the emotionally disturbed kids are happily playing on the playground, but Patrick is standing on the sidewalk screaming and complaining and protesting, having to take a time out. I'm thinking, oh my gosh, maybe I should enroll him. So that's the kind of thing that we're dealing with here. That's the kind of intensity and difficulty. He really was kind of on a par with kids that were at Edgefield Children's Center. All right, so here's some things we learned. Emphasize the positive rather than the negative. These kids really, they're looking for stimulation. That's the thing that they all have in common. They're looking for stimulation. They want fun, exciting things to happen. And actually, as you remember Patrick running along, he didn't mind falling down and hitting himself on the ground. He didn't mind walking into the telephone pole, right? It's just another form of stimulation. So getting into an argument with you, having you yell at him, telling you he better go to timeout right now, your face gets all red and everything, that's pretty damn interesting, right? That's fun. Look, I'm having an effect. This is really interesting. What made that happen? Can I do it again? Push that button another time. You know what I'm talking about? They think it's fun. They're willing to tolerate some pain in order to get this entertainment. So you don't want to spend a lot of time noticing negative things because it's reinforcing. They think it's fun. They thrive generally on excitement and intensity. So you want to make it fun to do the thing you want them to do. Can anybody think of a way that you would make it fun to do? Let's say you have a toddler, you're trying to get them clean up. What's that?
Clean their room.
Clean their room. Okay. You're trying to get
Make
them
a
clean
race out of it. How fast can you do
How
it?
fast can you do it? Yes, use the timer, right?
I bet you can do it faster than I can.
Right. We're gonna have a contest to see who can get the most blocks into this thing first. Ready? Go. They love that stuff. It's fun. And then when they're done, you have to be really mad that they beat you. You let them win, and you're like, ah, God, oh, you beat me. Darn it. They think it's hilarious. Make acting out very boring. Give the consequences totally flat, no emotions. Like, okay, time out. You want to go? You know what happens. I'm going to go read my book now. Let me know when you're done with your time out. Just keep it really flat. Also, this is important. Allow the child to earn back part of their privileges because they get mad when they feel like they've been. The injustice is like really important to these kids. So they get mad when they feel like they've lost something. So if you give them an opportunity to say, well, okay, if you do this and this and this, you can earn back some of your privileges, then they will be more motivated to do the positive thing. Again, you can then reinforce them for doing right instead of punishing. Does that make sense? Mm-hmm. Okay.
That's cool.
So that fits with don't let them dig a hole too deep because if they feel like there's no way to get out of the hole, they're like, hey, what have I got to lose? I might as well go for broke, right? Okay. Programming. Come up with goals together. No more than 2 or 3. Sometimes 1. Sometimes 1 is all I can handle. Use immediate reinforcement. Something chosen by the child. We used to use like shiny stickers that they would pick out, learning palace. Sometimes you can use physical reinforcement, hugs and time together, those kinds of things. And then when you get a certain number of those things together, you do something fun together. And again, you want to make it something intense, something that they pick. If it means something that they make you have to do, it's really kind of even more fun. Kevin at one point was having a hard time when he going to bed that he didn't want to. He would go do his teeth, right, and then he would take a long time and goof around and everything, and I would nag him and everything. I'm like, it's stupid, you know better than this. So one night I brought my book along with me, and it's because it was reading time, and I said, okay, as soon as you're done with your teeth, we're going to read, but take as long as you want, because I got my book here and it's a really good book, and I'm enjoying it. So just take as long as you want in that bathroom. 2 minutes later, he is back. And I'm like, are you done already? He's like, yeah. It's like, can I just, I'm a really good part. Can I just read a little more? He's like, no. And like, I have to read to you, darn it. And I like bring the book down the bed. I'm like, oh, fine, give me the book. He laughed and laughed and laughed. He thought it was hilarious. And even after I'd done it 2 or 3 times, and he knew it was a game, he still thought it was funny, funny, funny. I still pulled it with him when he was a teenager, and he swore it didn't work, but it continued to work. Use TV video time as a reward. Not something they can do all the time. Yes.
Yeah.
Go ahead.
Okay. That is another thing that's extremely difficult in a class setting because most in school because most of their homework is now 99% of it is now computer based.
Yep.
And you can't stop them from going to something else.
Right.
You just and you have to actually continuously watch their screen.
Wow.
Yeah. Well, and you may have to, in that kind of case, you may have to say, if you can continue on this particular subject for X number of time, then I will allow you to do it. Some programs have passwords, or if you can have a part where you can continue, but
they're smart enough to
it's hard to do. That's right. They know more about it than you do.
Yeah, yeah.
All right. It's also a good idea to forget the reinforcer when they're being good. Remember that they don't have great memories. They're living in the moment, right? So after they start getting the reinforcement, one of the things about reinforcement programs is that sometimes kids will stop if they don't get the reinforcement. But these guys, especially if you add the social reinforcement with it, after a while you just forget to give it to them, and if they don't ask it for you, then they just start making it a regular habit. And then you jack up.
Well, and I mean, like just basic behavioral conditioning is if always reinforcing a behavior is not as effective as occasionally reinforcing.
Yeah, exactly. What do you call it? The slot machine effect. You know, you got to pull 10 times to see if you're going to get the reward. And then when they're doing better, then you increase the goal to a higher level. Yeah.
What I was going to say is one thing that we personally changed from Patrick to Kevin was we realized with Kevin that we need to be really concrete, and that's what Patrick needed, and it took us a while to figure that out. Really concrete, that if you do this, here's what's going to happen, whether you're doing a reward thing or not.
Right.
And like with Kevin, he was so active and could crawl well at 5 months. Literally put him in the playpen for 10 seconds.
Yeah,
we got the idea.
We started timeouts with me at 6 months. 6 months he could crawl up the stairs. He was crazy. All right, paradoxical approaches. You kids like this tend to be oppositional. You can use this to your advantage. Betting is my favorite. You bet the child that they can't do what you want them to do. Kevin had a really hard time settling down for bed. He would smuggle toys and he would play with his socks or whatever the covers were. So I bet him. I said, I bet you a quarter you can't stay still for a minute without moving. He's like, I can't do it. I was like, no, you can't. I can't do it. All right, ready, start. So I had to wait like a minute and a half before I could even start the clock because it was so wiggly the first time around. But I waited until he won, and of course I gave up the quarter begrudgingly. Like, oh, dang it. But tomorrow we're going for a minute and a half, and I know you can't do that one. And so we did that for about 2 weeks, and we got up to 5 minutes. And by the end of the second week, when we got to that 5-minute point, he would immediately just go like, So don't tell me that they can't learn. Don't tell me that there's a switch there that they can't run. It's a matter of motivating the kid to learn how to do the process. And then we got to the end of it. I said, well, I guess you can control your behavior if you want to. You just really have to decide that that's what you want to do.
Wow.
That was pretty powerful. Timers. Make it a challenge to complete something before the clock rings. Crosstalk is a good one I learned at Edgefield. You talk to your partner or somebody else about the likelihood of them doing something. You say, Patrick's going to take a really long time to get dressed. He's very predictable. They hate being predicted to. He's very predictable. You know it's going to take a long time. And then Gina will say, well, I don't know. I think he could do it. You're like, no, come on. There's no way. You may even make a bet with them and say, all right, I'll bet you a quarter he's not going to be down here in 5 minutes. So again, it makes it fun. You're not talking to them. You're not punishing them. You're not giving them attention for acting out. But you're talking about them doing the right thing. And also talking about the decision. You're making them have to think, what am I going to do? Which is another fault of these kids because they're living in the moment. They don't think ahead. So you're actually plotting for them what the future could look like. Could you go this way? Could you go that way? In a way that doesn't directly engage them when they're not acting out. Does that make sense? All right, I'm running out of time here. So the more fun it is, the better. If you can have them defeat you in the process of doing something boring, it's always a good idea. Family meetings, you probably know about that. It's best if they make the rules up. You want to write down what you agree to and have them pick out the good and the bad consequences. One time, Kevin and Patrick and Sean were having trouble with fighting, arguing, not physically, and they said that they wanted to do push-ups. I was like, no, please, not push-ups. They're like, no, we want to do push-ups. I'm like, no, come on, can't you come with something? No, we're going to do push-ups. So we agreed to do push-ups. We were in the middle of Winco Foods. They started having an argument. I'm like, okay, guys, you know the deal. They dropped down in the middle of Winco Foods. They were doing push-ups. And this one lady came by, gave me the dirtiest look. And I said to her, it's not my idea. They wanted to do this. But I was some kind of maniacal, super militaristic dad. The other thing that's kind of fun is if you set up a situation where you're not allowed to swear and you have to put a coin in the swear jar, right? If you have to do the same thing, they like that because then they can catch you. They say, you swore, you have to put the coin in. So they feel like they have some power. It makes it more fun for them to comply because they can say, I'm better than you at that. And then you review those rules as you needed. And it's nice if they can do it to let them lead sometimes.
What do you mean by that?
Let them lead the meeting. Let them be the chairperson. And they kind of like that sometimes. Gives them a new role, something to do. So energy points was my favorite thing that I invented. This is brilliant. I invented this. Create a need to figure out what I need. So you start each day at 0 energy points. You get +1 if you do something that makes me feel more energetic. You get -1 if you drain my energy out. If you go below 0, I don't do anything for you. I don't make lunch. I don't drive anywhere. I don't play basketball. I don't talk to you. I don't do anything until you get back on the positives.
And you can do it concretely, like if you're playing like bingo chips or poker chips. with a jar. We even did that for a while, and then you can really see.
Right. And of course, arguing makes you lose another point. If you argue about, I shouldn't have lost the point, well, now you lost another point. You don't want to go below -2. I figured this out because then they're dug in too deep and they don't want to play anymore. But then you give them jobs that they can do or some other way that they can earn back points. But you make them think of it. It's like, what's going to make me feel more energetic? You tell me. So it forces them, again, to plan ahead. And it forces them also to think about how you might feel, which is often a deficiency in these kids, is that they just do what they think they want to do and they don't really think about you and what's going to be, how you feel. You try to be positive preemptively. You don't wait till they do something bad. You spend positive, intense time together before anything bad happens. We used to just take like 5 minutes in the morning and just do something fun. We just throw them up in the air, tickle over, and run around, or do something that was fun for them, and that would immediately set them off on a really good foot. You ignore again the negative behavior to the extent humanly possible, and anything that they do that required consideration or patience for them to do something that might be bold, you make sure that you acknowledge them with intensity. Like, wow, thank you so much. That is so cool that you washed the dish for me. I can't believe you did that. That is awesome. Thank you. You made me feel really good. Just really go overboard because they're looking for that intensity. Environmental management stuff, you precede exciting things with dull necessities. When you're done with this, then we're going to do this fun thing. Make sure that if they do something that's hard or dull for them, that they get to do something fun right afterwards. Try to keep the dull things in short little bites. Give warnings for transition, really, really important. They do not like to suddenly stop things. In fact, that study I was talking about where they said that the kids in the regular classroom stood out like a sore thumb that had ADHD diagnoses. One of the things the researcher observed was that these kids were constantly being told to start and stop things. Mm-hmm. They're like, okay, take out your spelling books. They take the spelling books out. You work on spelling for 10 to 15 minutes. Like, okay, put your spelling books away. Take out your reading. Put that away. Take out your math. Okay, time to go to recess. Time to go to the bathroom. And it was like constantly being directed around, and it drove these kids crazy. They couldn't stand it. Because they'd be like, okay, we got 10 spelling words to learn by Friday. All right, I'm going to learn 10 spelling words. I'm going to learn them today. I'm not going to stop, like the tetherball, right? I'm not going to stop till I got these things learned. Well, I've only learned 4 of them, and I have to do math. I don't want to do math. I want to finish my spelling words. They get into it like that, right? So you have to give them a warning for a transition. Timers are really good for that, especially you can even have them set the timer when they get old enough. Say, okay, how much is 5 minutes? Go ahead, put it for 5 minutes. We're going to be leaving in 5 minutes. Turn the timer on. When the timer rings, we have to go. Take care of sleep, food, toileting. They forget. They don't want to go to the bathroom.
I think that is super important.
Yeah.
On the food piece,
it was
controlling the diet a lot. I mean, there are a lot of studies that show that.
Mm-hmm. Yeah, and when his blood sugar would go down, Patrick in particular, would just be a disaster. And we would start getting into some stuff and we couldn't manage it all. And we're like, okay, when's the last time he ate? Give him a banana. I do it with Ginny too. Yeah. She gets really grumpy. I'm like, eat a banana. She gets better. So they forget that
lack
stuff.
of sensitivity, like when he falls down and he doesn't, and he runs into the post, and it's like, oh no big deal. There's kind of there's same with my son. There was so much going on in his head that there was no body awareness,
right.
No awareness when they're tired or when they have to eat.
It's kind of like this out-of-body experience. They're constantly trying to create some kind of stimulation, excitement, and they're just really not paying any attention to what that body's feeling. Create external time structure. They're not good with time generally. If you use visuals too, a lot of them are visual learners rather than auditory, and you can say something over and over to them. But you give them a nice green card that says, here's the 3 things you need to do this morning and the times you need to do them by. It works a lot better. Or if you have a schedule posted up, that's really, really helpful. And then limit the time for those dull activities. Make them short. You want to make it something that they can succeed at. They can do, like I did with the holding still thing, right? If you can do it for a minute, then be proud of them for doing it for a minute, and then stretch it out to a minute and a half, rather than setting them up for failure, saying, okay, you're going to be cleaning this whole set of dishes here. Having to say, you're going to clean. How many do you think you can clean? You can clean 3. Okay, 3 dishes. Go for it. And then you do 3. That's awesome. Tomorrow, let's go for 4. Make sense? All right. You want to build on their strengths. There are lots of positives associated with ADHD. Talk about what they're good at, that they're smart, that they're athletically talented, that they're persistent. Identify those as strengths, even though persistence is stubbornness turned upside down, right? Don't tell them they're stubborn. Say, you're persistent. My son Sean, the non-ADHD one, he was a great liar. But I wouldn't say you lie a lot. I'd say you are good at telling stories. You're a great storyteller. That's a strength you have. Sometimes it's not really helpful when you choose to tell the stories, right? So talk about what they're good at. Frame the difficulties as challenges to be overcome with their strengths. Patrick, I one time remember having this conversation with him where he was talking about I can't remember what it was exactly, but we ended up talking about behavior with people. And I said, Patrick, you are great at math. Math is the easiest thing in the world for you. He actually could translate centigrade to Fahrenheit in his head, negative 100 degrees centigrade to Fahrenheit in his head when he was 6 years old. I was driving him to school. They saw those things with the time temperature. And he says, I don't know what minus 100 centigrade is in Fahrenheit. And he even knew that you had to add 32 at the end to adjust for the difference in the 2 0 points. Didn't tell him that at all. All I told him was there's 9 Fahrenheit every 5 centigrade. He did all the rest and said, geez. So he was super smart. So I said, math for some kids is really hard. For you, it's easy. You can do math in your head. A lot of kids have to work really, really hard to do math. I said, some kids find getting along with people really, really easy. For you, it's not. You have to work at it. That's your thing that you have to challenge yourself to do better. So it's always good to frame things that way where they don't feel like you're saying that they're bad all the time. And also always provide them with assurance that your love is not conditional on them behaving the way that you want. And that's a hard one sometimes. Lots of hugs and touches when things are going well. So, some recommended reading. Myth of the Hyperactive Child was how we started out. Peter Schrag and Diane Forkey. That was written back in the 70s before this was really a big thing, but they very much presaged what was coming. And that's where I learned a lot about the minimal brain damage history. Attention Deficit Disorder, A Different Perception. That's the farmer versus hunter by Tom Hartman. Really good. Raising Your Spirited Child talks about some of these behavioral techniques in a very positive way. This is a person who really believes the kind of things we're talking about here, that these kids are good kids that have some different needs, and we just try to approach them the way it works. Wild Colts Make the Best Horses by John Breeding, similar kind of idea. He's like, these kids are tough when they're kids, but they make great adults if you can survive their childhood. And then Suffer the Restless Children by Alfie Kohn, this Atlantic Monthly article that was written back in '89, and it just was the best description I ever saw of the whole complexities of this, not just the question of is medication working or not, but what is this ADHD thing and why are we doing this, and is it a good idea?
He also wrote a book called No Contest, where he talks about instead of giving rewards, you help kids, people, everybody develop internal and intrinsic motivation. So, yeah, interesting. Yeah, he was good.
So, I'm out of time.
Woohoo!
Do we have to get kicked out of here, or
Yeah.
do we have a few minutes, or do we have to go?
Well, I'd say give yourself 5 minutes.
I'll definitely be around for questions. I also have copies of the book here, Jerk Radar, in the back. Jerk Radar has nothing to do with ADHD whatsoever. It's about how to avoid an abusive relationship by recognizing that a person is mean when they're still acting nice. And lots of conversations with domestic violence survivors illustrating what their abusers were like when they started out. So he'll be in the back. I'll be here.
Can we, nobody's come right now. If there's a comment or
Do you
two.
have any questions? Or?
I just wanted to throw out that in May, the Arrow Conference, which is free school, open school from all around the country, and this year the international one is going to be in America at the same time, and that only happens every 7 years. And that's, if you look up AERO, the Arrow Conference in free school, I'm sure you'll find it on Google. I've gone several years, and it's just amazing to talk to the children as well as the teachers and all the other folks.
And you reminded me to mention that part of this process for Kevin Yenningsbury was that we actually helped to create a school that has the kind of open classroom setting that these kind of kids work best in. It was very child-centered, where you have lots of options, and kids don't all have to be the same age, doing the same thing. When he was in first kindergarten, or first grade, he was working with third graders on math and that kind of thing. He was in 7th grade. He was on the high school Frisbee team. It's called the Trillium Charter School in North Portland. And so if you have kids that are kind of like this and they're in Portland Public, it's a great place to consider.
Can I make an announcement about an upcoming event?
Do we have any other questions real quick before we do the announcement? Any last comments? Yeah.
Quick question, would you be able to share your slides with us?
I'm going to figure out a way to get those up on the website, absolutely.
And we'll see if we could put the whole presentation on. We keep experimenting with doing this, and it somehow hasn't. None of them have gotten on the website, but we're hoping
to figure it out.
To figure it out.
Yep.
I just wanted to say that if people here are concerned about the globalization of the mental health crisis and the current paradigm of mental health care, a good segue into examining some of the economic and social forces that are driving the epidemic of mental illness. There's a good opportunity to get together and network folks on the other side of this issue at the Economics of Happiness Conference taking place at the Unitarian Church at Elliott Hall, February 27th to March 1st. It's for grassroots activists. It costs $50 to attend for all 3 days, but there are still scholarships available. So if you Google Economics of Happiness in Portland, you can get a scholarship. And I'm proud to say that Rethinking Psychiatry is going to be a co-sponsor of that event. If you're willing to volunteer to table for us at that event, you can get a free ticket for the whole 3-day event.